In progress.
Okay, good morning. It is November 3rd. We are here in PACU and starting our presentation of pain reassessment with our senior nursing student, Toby, I'm sorry, I keep saying that. If it feels natural to say Tony, but whoever. Okay, you can go ahead, and if you know how to click through just down here to hover.
All right, hi everybody. So this will be on pain reassessment. So a little bit about me, my name is Toby Weber. As said, I'm a senior nursing student at U of M. Currently my leadership clinical with Noreen over here. Today's my last day. I work at the Ann Arbor VA. I've done stuff in their endoscopy unit and in their oncology. Really enjoyed it there and plan to stay on after I graduate. I'm interested in endoscopy nursing just because of what I did over the summer. I'm from Ferndale, Michigan, so that's about 45 minutes away from here. And I have two cats, which are pictured here. Their names are Lorenzo and 444. So why is pain management important? First things first, it keeps the patient comfortable, which is always good. It can help speed up recovery, reduce chances of complications like pneumonia and blood clots in the patient. And also something I didn't know, but unrelieved pain activates the pituitary adrenal axis, so it releases all these hormones, which can suppress the immune system, and then that can result in post-surgical infection and poor wound healing, which could result in someone coming back to the hospital, so it's important to keep all that managed. Different types of pain management, I'm sure you guys are familiar with a lot of these here. We've got PCA pumps, epidurals, nerve blocks, opioids, non-opioid analgesics, NSAIDs, and non-pharmacologic techniques. Some reminders when assessing pain. Pain is different for everybody. So some people may have different tolerances, all that kind of stuff. Characteristics of pain, it can be dull, stabbing, cramping, throbbing, constant, on and off, etc. Treating pain early usually brings quicker and better control. And it's important to stay on top of pain management. So administering medications early, not waiting too long, because then it's harder to manage it. As said before, healing occurs faster when pain is under control, and pain also affects stuff like blood pressure, heart rate, appetite, and mood. So comfortable patients typically are a happier one. Aspen guidelines on pain management. So you want to make sure you assess your pain within 2 hours of patient admission, within 30 minutes following any scheduled or unscheduled IV pain medication, PCA starts, epidural starts, or boluses. Within 1 hour following any scheduled or unscheduled oral medication, and then any medication that prompts pain assessment when scanning requires reassessment in the charting. So hospital guidelines, I'm sure you guys are all familiar with this little handout thing, but if not, there's probably some extras. But reassessment of pain after opioid administration is supposed to be done after 1 hour. You've got your little flow sheets here. So I had sent out a survey to you guys a couple of weeks ago, so thank you for filling that out as well, asking if you'd reassessed your patient's pain within 60 minutes. Almost everybody said yes. We got 14 people who said yes, and 1 person said no. And the reasons why they said no was because there was not enough time or they were too busy. They forgot to input the pain score, and they entered the pain score after the time limit. So that's after that 60 minutes. And then for like auditing of my chart, the percent of on time for all reassessment requirements is 33% in September, which was the best percent for all requirements all year. So it's very good. It's been trending upwards for the past 3 months. So that's been looking good. We'd want to see 100%. Yeah. So that's like for putting in the reassessments within the 60 minutes. Some barriers to pain reassessment, as said before. If the patient is awake, there could be more to do and it gets a little bit busy. You might get caught up doing something else and forget, or the pain reassessment could not be put in on time due to external events. If you have an emergency with another patient or like that kind of stuff. And then any feedback for you guys, if there's any specifics and stuff that make it hard for pain reassessment, or any suggestions on how to make things easier.
Sorry, I missed the first part of your slide, but I think the hospital policy for the 60 minutes, like we kind of are grandfathered into that because we are reassessing so often here. But we are required to, every time that you give a pain medicine, you are to follow up with a reassessment. So it's 60 minutes, 30 or 30. Sorry, I might have said it's 30. Yeah. We do hourly assessment. So if you give your last dose of pain medicine within, actually, I think it's 60. What graph did you? Yeah, it's 60.
This one?
It's
That one I thought you said was hospital wide, but the ASPAN standard slide is 30.
Oh.
That's 30 for IV pain medication, and then an hour for oral.
An hour.
But this is the hospital guidelines right here.
We're 30%.
Yeah.
So we were at 30%.
Yeah.
Is that just PACU's percentage or the whole?
Yeah, this is PACU.
And then just less those payments, like if you do every 5 minutes, it's
Right, yeah.
That's what I was gonna say, is like.
This is just for each like medication, what percentage has the,
they get that last dose. That's-
Right, yeah.
For an hour, yeah. So
Mhm.
that.
I don't believe so, but I'm not sure.
Yeah.
Yeah.
I think. Because we are, like, we're giving the last dose and then it might be another 4 hours.
But also, that wouldn't be under us.
No.
But also doing chart audits.
I was trying to think like one year.
Yeah, I don't know why they don't do hard stuff, like if you've never done it in an hour, it helps something.
Right.
I agree, Noreen, because we have so many of those prompts that come up. I have never seen a prompt.
Pain.
And you would think that we could incorporate that if the patient gets scanned or gets an opioid scan for any reason, that would immediately like put a timer on it. So it would prompt. So if you want to do it with Aspen standards, it would be every 30 minutes. And you could, and it would just pop up within that 30-minute time.
Well, on the floors, they have like the brain that we don't have access to down here, and it does like have that reminder in there.
In the ER charting, it does, wow, like if you give a narcotic and then after 30 minutes, it, an automatic, like it pops
Right.
up, like you're due for this assessment. So we can ask our uptime committee and see if that's something.
I mean, they obviously can, because they're doing a hard stuff about discharge.
Right.
So,
Yeah.
but if you complete, they won't let you complete it unless you.
And you can get the reminder for
Right, exactly. And you would think that once you like, if you're doing every 5-minute fentanyl, if you scan it again, you wouldn't get the 30-minute from the first dose. You would get the 30 minutes for the next second. So,
Yeah.
so if you're doing it every 5 minutes times 3 doses, you wouldn't get but one thing because you're already doing your reassessment every time you're giving the assessment.
what's my already started.
Yeah.
But one of the problems I did notice before with those, or would they be prompt you, is when you click on it, it'll have you do it in real time what that pain score is, not what the hour pain score. So if you like didn't pay attention, you have to like go back. It's not like you still have to click in and look to see what time do I have to document this for, not what time it is. So if they did a reminder and could make it for the time it's supposed to be, yeah, that would.
That's a lot. I would say we have to work on it, but like, we are doing chart on it. Maybe we can try to put it for awareness, you know. We should have a reassessment part.
To enable it.
Yeah, that's right.
Are there any questions in the chat? I don't know.
There you go.
Yeah, I think too, the difference of just what the slides say, not to confuse, and even I was confused. 30 is ASBAN guidelines, but our hospital policy is 1 hour.
Mhm.
So that makes,
Next meeting, we decide to follow Aspen guidelines for everything. Want to make it Aspen that way, maybe we're catching one, or do we follow? I don't know if our numbers would be worse or better.
were those all your slides?
So if you're, say you give just the 3 doses of them and you don't require any longer. 30 minutes after the last dose, you do your reassessment. And they're here for an additional 45 minutes. Do you need to do another reassessment? Is it just hourly after that if you're not giving any more medication, or is it
Right, I would, that's something that we have to clarify. Because what if they transport by them, really?
right?
Or should we be doing more assessment for it? I don't know where that. Because think about it, realistically, by the time they transport, by the time they get up there, by the time the nurse is in there, upstairs, by past it. Realistic. So. We'll have to find out where should we be doing one right at this. Like 30 minutes before they leave. I don't know if that's the somewhere or if that depends on what they want in this, you know, what are they looking?
All right, good job. Thank you for
Thank
all
you,
the
everybody.
information. We still have a resident that's gonna do a presentation. Was he? Okay. Good job, Toby.
Question. Right. Maybe we probably have some students. Because the problem, I think that all came about. Type it back down to PACU. I'll be charged for the last hour of them being in PACU. Or, you know, we have a transport with that people, you know, could be given that.
All right, I got your slideshow here.
Are they doing that assessment again? Or, you know, it's not always on the hour. I don't know. If they go up with it.
Still recording, so. All right, we're gonna transition into Dr. Paul Shea, one of our anesthesia residents. He's gonna talk to us about obstructive sleep apnea. Do you need presenter view or just slideshow is good?
Yeah, slideshow's fine.
That's good, okay. I can get rid of these. Okay. All right, take it away. Thanks
right.
for your time being here.
I'm Paul. I'm going to be talking about obstructive sleep apnea in the perioperative environment and some of the considerations that we might want to look at preoperatively, intraoperatively, and pertinent to here postoperatively. So
And, you hover over here, or that works too.
Oh,
I don't know why the captions are on over here. It'll advance your slides.
okay. So a little bit about me. Born in Ann Arbor, Michigan. I played ice hockey growing up. I'm a Pioneer High School alumnus. Go Perps. Studied anthropology at U of M. Got a public health degree in epidemiology. And I also worked as an anesthesia tech for most of this time. Decided I didn't like public health. I liked the OR better. And so wanted to go to medical school. Went to Wayne State. My mom was a CRNA. She's been retired for a couple of years. If anybody's been here a long time, they may have worked with her in the past. And I have a wife and dog. Yes. I also might have OSA. So it's a topic that hits close to home for me.
The mask, the glasses, no cap.
Yeah.
It's different than, yeah. Is that what you're saying? You're like, wait,
That's not really, I've got hair, like, it was just like a joke picture, but
gotcha.
I like crude medical humor. I don't know, this has nothing to do with anything we're talking about today, but this is kind of like sums up how I felt last year as an intern. So I'm really enjoying residency. It's been really great to like get into the ORs and start doing anesthesia stuff. But you know, there were some like rough months on the gen med wards, and it was pretty much like this every day. So this is my puppy. His name is Blue. He is a chocolate lab. He's a year and a half. He's about 100 pounds. Like, my wife's never had a dog before, and I told her like, oh, it's not going to be a huge deal. And yeah, he's big, a lot stronger than her. So, but you know, we're coping. So I'll talk about the epidemiology a little bit. You know, 4% of middle-aged men, 2% of middle-aged women. You know, I would take these numbers with a grain of salt. I'm not really sure I believe this. I think you could walk around our operating rooms and kind of do a sample yourself and say that guy looks like he has OSA, or this person looks like they have OSA. You know, the incidence and the prevalence of this is dynamic. You know, somebody loses weight and now they don't have sleep apnea anymore, or somebody gains weight and then they have sleep apnea. And then there are probably a lot of people with mild symptoms that never get sleep studies, or people with moderate to severe symptoms that never even get sleep studies. So it's kind of like, you know, this is a little bit misleading. I think if we were to say what's the epidemiology of, you know, upper airway obstruction, right, which doesn't require diagnosis with a sleep study, it'd be probably a lot higher. So some of the many faces of OSA. Maybe forward.
Really? Yes.
Yeah.
Yeah, I can see that.
You can just, I don't know who's starting their own meeting, Tammy.
John Candy, who would have thought? Yeah. Rosie O'Donnell. Randy Jackson, although he's lost
a lot of weight.
Yeah, he did, but previously known to have OSA. So some of the big risk factors, there are others, but these are the major ones. And the number one risk factor is going to be obesity, BMI above 28, male, middle-aged, and then alcohol plus or minus sedative use. This is a MAC5 blade. I think we might have one laying around the department somewhere. But yeah, this is like your MAC5 patient or MAC4 patient. So pathophysiology, really what's happening here is you have a loss of upper airway tone, you have collapse of the soft structures towards the back of the throat. When you're still able to get air past, that's your snoring, right? Your partial airway obstruction, very common. In anesthesia, we tend to cause complete airway obstruction eventually with our drugs. And that's what you see when somebody goes apneic. So some of the things that are going to cause this, obviously, if you have known or suspected OSA, but also something we see a lot here, residual anesthetic, residual paralytic, not quite as common nowadays with Sugamidex, and then also postoperative opioids. So some of the clinical features, you know, a patient may tell you that they snore, they choke, they gasp, but a lot of times, you know, that bed partner or family member at the bedside's going to be helpful in teasing this out, as you guys know. Snoring, not very specific, but nocturnal choking and gasping, very specific in terms of ruling in suspected sleep apnea. Some of the other things you might hear from the patient: daytime sleepiness, fatigue, low energy, poor focus, and then falling asleep in boring, passive, or monotonous situations. So that's typically what happens to me every night when my wife puts on forensic files, and then I like fall asleep. Yeah, that's what we watch. Other things: morning headache. You're going to see this 10 to 30% of people with untreated OSA. Bifrontal squeezing headache. It's not like your typical migraine where you're going to have like nausea, light sensitivity. Usually occurs in the morning, goes away, and usually this is an indicator of severe undiagnosed OSA when you have this morning headache. You also see nocturia, and then a whole host of other associated conditions. Postoperative hypoxemia, hypercapnia would be our most relevant to us. And we already talked about some of the symptoms here on the left side of the slide, but I just wanted to highlight over here on the right side. There are some pretty serious comorbid conditions you're typically going to see with these patients. You're going to see dysrhythmias, cerebral vascular disease, stroke, metabolic syndrome goes along with the obesity, but also some really scary ones like pulmonary hypertension. And then just, uncontrolled systemic hypertension. So, these can be some complicated patients. So the diagnosis, one source that I was reading said, it can be based on your clinical impression, but really the gold standard is going to be, your sleep study. So with the sleep study, what we're trying to get at is the apnea-hypopnea index. Apnea being a complete cessation of breathing for 10 seconds or more. We can see in the first column of that slide there, at the top, airflow and O2 level. And then hypopnea is going to be 10 seconds or more decrease in ventilation, or if you get an SPO decrease of 3 to 4% from baseline, which we can see also in the top two boxes of the hypopnea column. So then we can stratify people based on severity of their OSA, based on their apnea-hypopnea index, and then we can also compute an OSA severity score, which can be used for other sorts of perioperative risk stratification. So just like a break. So this is him. I don't know. He was probably like 7, 8 months. My wife likes to dress him up and stuff. You can tell like he doesn't like it. I think my favorite one is the St. Patrick's one. He just like looks like get me out of here. But yeah, anyways, that's our guy. So mainstay of treatment is going to be risk reduction, weight loss, lifestyle modification, a good pharmacological review, and then positive airway pressure. So CPAP or BiPAP in some form. This is a little video on the jaw thrust maneuver. This is so like, you have somebody obstructing in front of you and, doesn't matter if they have sleep apnea or not, but you may need to give them a jaw thrust. And it's a good temporizing measure. Sometimes, it can just get you through what you need to do. But I thought this was really interesting because they did a jaw thrust while somebody, and this is like not like a guy who has like a OSA looking body habitus, but it shows like what the airway does, during the jaw thrust, which I thought was very interesting. So you can see there's no sound, but you can see like just with that jaw thrust, you're opening up the whole airway. Without it, it's pretty collapsed down. Now, if you've got like, a bunch of soft tissue and weight on top of that, you can imagine you might not be moving very much air through. So just thought that was interesting. So how do we risk stratify these patients, especially when we suspect that they might have OSA, but they don't have a formal diagnosis? So many of you are familiar with the stop bang questionnaire. So some of the clinical features we talked about, but also asks about, hypertension, BMI, age, neck circumference is a big thing, male gender. And so each one of these gets 1 point. And so then when you have a suspected obstructive sleep apnea patient, then you can kind of stratify them: low risk, intermediate risk, high risk based on your stop bang. And you can say, okay, is this person going to, be appropriate for surgery? Is this person going to need additional workup before we go into surgery? And what might this person look like, coming out of the OR? And if you can sort of guide your management, and you can say, well, if somebody has intermediate or if they're high risk, and they've got to have the surgery, then you might want to be a little more judicious with your pain management intraoperatively. You might not want to give a full, pre-medication of Versed, just because all these things are going to, impact how they're going to do post-operatively. And then if you have somebody who has known diagnosed OSA with a sleep study, you can kind of stratify them moderate to severe or mild. Mild patients, they should be on their PAP therapy, encourage risk factor reduction, weight loss. Moderate to severe, these patients should have their CPAP devices with them in the hospital when they come in for the procedure. Should anticipate definitely being on some positive pressure after their procedure as well. So as I was just mentioning, what are some of the considerations that we might have? Airway wise, you're going to want to have OPAs and MPAs readily available really at all times for these patients, especially if they're getting sleepy and obstructing. And then light scope is always a good consideration when you have sort of these larger necks, which may be associated with difficult airways. And then the pain control, you want to have it be multimodal. You want to try and limit post-op respiratory depression, limiting benzodiazepines, going with shorter acting drugs. So your propofols, your rock sucks, remifentanil is a good one as well for these patients. And then, we can't always totally get away from narcotics because these people are having like major procedures and they're painful. So, but I think the most important thing is, judicious use of opioids. You can always give more, but you can't necessarily give less once you've already given it. And then also your adjuncts. So, advocating for, use of Toradol where appropriate, and then making sure that we get Tylenol, making sure that we're using regional techniques where applicable as well. And then in terms of waking these people up, you don't want them fully awake before you pull the tube. You want them sitting upright. And then, when I have a patient with OSA, I take an oral airway, I tuck it under the pillow, and I bring it all the way into PACU. It's just something I want to have with me at all times with that patient. Yeah, well,
Because sometimes we're scrambled. I just was looking at a back, like looking for a nasal trumpet or an oral airway. We have them, but then it's different.
yeah, it's already been in their mouth, and we're just, you leave it in if they're not gagging on it. Just leave it in. It's just an extra layer of safety, and as we like to say, wards off evil spirits. So these patients should typically be getting supplemental oxygen after they're extubated, during transport to PACU, on PACU arrival as well. Then you can consider, waking some of these people up with like Thrive or high flow nasal cannula, and you can get a little bit of positive pressure, with that high flow, but not like you would see on a like a CPAP machine or like a true ventilator. And then obviously you want to have your CPAP device, your BiPAP at the bedside postoperatively for these patients, unless there's some sort of surgical contraindication, positive pressure in the airway. So I want to kind of talk a little bit about like perioperative risk. So these patients are at risk of having, complications, related to the cerebral vascular events or other like critical cardiac events because they also often have a lot of comorbid conditions. This is from a study, and so take this all with, there's a big asterisk on this. This is a compendium of case reports, 60 case reports retrospectively reviewed of patients that had, critical events or, like a cerebrovascular event in the blue post-operatively. And what it showed was that you can't really see right now with, we'll just move that over here. But our sort of high risk time for this based on their case report analysis was that first 24 hours. That's when would be sort of the danger zone for these patients, but not necessarily ending there. And then perioperative risk based on location events. So we see that a lot of things happen on the floor, but 31% of these complications were actually occurring in the operating room or the PACU. So, so definitely requires a lot of vigilance on our part. So disposition for these patients once they get to the PACU. So, you know, you may want to monitor these patients a little bit longer, go a little bit slower with everything you're doing with them. If you've got suspected OSA and you're you know, it looks like their screening scores are on the higher side. If you're having recurrent respiratory events, if they're requiring a lot of IV opioids, you know, you probably want to have a postoperative monitor bed. And I know that's not always feasible given, you know, the logistics and bed crunches and stuff like that. But you probably want to consider starting some positive pressure on these patients and, you know, having continuous pulse oximetry overnight for these guys. But you know, if they're doing okay and you know, they're not having recurrent respiratory events, they can probably go home. They have known diagnosed OSA, significant comorbidities. If it's moderate or severe, they're non-compliant with their therapy. You know, these are definitely people that I would want to have a post-operative monitor bed. And that should be something, you know, a discussion that should happen beforehand between surgeon and anesthesia. Say, hey, you know, this is probably not a guy who's who we'd like, you know, just go home after the surgery. This is somebody we want to watch a little bit longer. And then, so this kind of breaks things down into, you know, what are some of the predictors for, you know, how someone with severe OSA or moderate OSA is going to do postoperatively. So you have your OSA severity score here, and then you look at the invasiveness of surgery and anesthesia, which is the second table here, and you have an invasive score. Or instead of using the invasive surgery, you can take the predictive postoperative opioid utilization and come up with a score there where you think they're going to be. And this is a chart that I found from Miller, but you can come up with a severity score, or you can come up with a score here with basically, if it's greater than 5, you're going to have, you know, significantly increased perioperative risk of having an adverse event for these patients. So, and that is all I have for you. Any questions?
I did have, somebody asked, I think, no, it was Karen, asked me about, to ask you, what do you know about the Inspire as far as treatment? Like, have you heard it? Like, I think we see it on TV, or even like a nerve stimulator implant that they're treating for OSA. I don't know. I think they do that procedure here.
Yeah.
I don't know if there's been, or if you saw anything as far as success rate with that. Or
You know what?
comment you had.
I didn't see it, and it's probably something I should incorporate into the presentation. I do believe you have to, you know, you have to attempt, you know, risk factor reduction. So you have to try and lose weight, and I believe you've got to like show that you've been on CPAP or BiPAP and that you've been compliant with that therapy for X amount of time before, you know, before you can get that approved to have the stimulator. So I don't think that that's like the first line thing that it's, you know, oh, I've got bad OSA, I'm going to go straight to that. But that's a good point. I would like to look up some of those success rates. So, and those are also tricky patients because, you know, we had one the other day, and I was just kind of learning about this whole thing, and I was saying, okay, is the stimulator on? And they're like, no, it's not going to be turned on for like 3 weeks. So this is somebody who like had sleep apnea that was severe enough that, you know, conventional treatments, you know, had not worked for this person, right? And now they've got this, you know, high risk period for 3 weeks. And the surgical resident was like, oh, he'll be fine. But I was like, I mean, I don't know. It just seems kind of tenuous. So, so yeah, I would like to look more into that.
Yeah. I don't know if there's anything in the chat. What's your dog's name?
His name's Blue.
Okay,
Yeah.
of course, you're Michigan.
Yeah.
fan.
Yeah.
How about them?
Proud.
You know, we have those people who- they can't use their CPAP, sleep apnea, and they come out, they can't use any of them.
Yeah.
What is the alternative?
Nothing.
We do.
Yeah, be careful.
Pray.
Be careful,
Yeah, I
yeah.
know.
I mean, be careful with narcotics, and I like to have people both.
Really light.
So.
Also a good reminder. Especially someone that is like the current ethnic episode impact you. And if you guys are worried about sending them home like that, come to us. They should, just like, Paul's slide said, probably be observed overnight. Because the data shows your biggest risk of death, right, is in that first 24 hours. So if you have a patient that you're worried about, get us involved so we can share your concern and reinforce that message with the surgical team. Because yeah, you really worry about sending someone that's constantly desatting and PACU, and they're like, okay, wake up, look at the sagging spine. It's like, no, that's not how we do it. You know. Anyway,
That first 24 hours is key to like, it's detrimental to know if they're gonna tank or not, obviously.
And it just anecdotally, because my wife is like these two guys' size and snores like a drunken person. So if they're snoring, don't immediately think that it's just sedation. It's just because they had anesthesia. If they're snoring, then it may be, she's tiny and she has been using CPAP religiously for over 15 years.
Yeah.
And she was a person who had a procedure, and they just kept waking her up because she would be sat into the low 80s during her PACU stay, and she was an outpatient. So
Yeah.
it's one of those things that if they're snoring, rule out. OSA, don't immediately think, oh, they're just sleepy, and if we position them.
Is there something, because I tell everybody that I discharged with OSA, wear your CPAP when you go home.
Yes, even if you're taking a nap. Yeah.
So I tell everyone.
They want to get out of here, like, we should.
I don't know if you could search in like the hospital clearinghouse for like OSA teaching, just the generic form. I'd have to look it up. Maybe that's something that we can even add to our anesthesia like portion that we just automatically attach. I don't know. I imagine there's something out there hospital wide in like our clearinghouse that we can search broadly for
A
that.
lot of people.
Yeah, even just a nap, like, or whatever.
Especially after surgery.
Yeah,
Yeah.
You're gonna sleep, please wear.
yeah.
And
That's a
in the
good
lazy
point.
boy. Where is it?
Yeah, exactly.
Sleep in the lazy boy.
Sleep in a
Even
sleep
the
in
lazy
sitting on
boy.
your recliner with your CPAP and have someone watch you. Don't breathe it.
Absolutely.
Good stuff. Any questions out there on Zoom? Throw them in the chat if you do. This is good. Thank you. We
Thank you.
appreciate your time.
Trying to clean up where in the slides. With the
Oh,
basic.
oh, sure. Yeah, that I can attach. Perfect. I mean, we enjoy the dog and everything too, but thank you.